Okay, start.
Assalamualaikum warahmatullahi wabarakatuh. My name is Fadzil, and I'm going to be the first presenter. So for today's procedure presentation, we'll start with lumbar puncture. So so this is my outline. First, we will go through the basic concept regarding its anatomy, puncture site, indications, and also contraindications. And later on, we will go into the details regarding its preparations, procedure, and also complications. So basically, one thing that we need to know that is the lumbar puncture is one of the important procedure since it related with one's central nervous system, either in pediatric patient or even in adults. So it can be commonly done. So what is lumbar puncture? It refers to the insertion of a specialized needle, which is a silent needle that get into the lumbar arachnoid space to gain access to the cerebral spinal fluid, the CSF. So, in order for us to obtain the cerebral spinal fluid, we need to get through the needle itself. We need to get through the subarachnoid space. However, with the space, the needle must get through over 10 layers of the body posteriorly through the lumbar part to get into the subarachnoid space, since it is the only space that contains the CSF. So if you can see through this picture, the skin, the hair, muscle, ligament, and so on. And then at last part, we get into the subarachnoid space so that there is CSF. So we're done regarding the anatomy. So where is the site that we need to put the insert needle to ensure that we do not do anything wrong or to cause complication to the CNS part, which is the spinal cord. We need to the puncture site must be below the termination of the spinal cord. And then at birth, the spinal cord ends at L3, but in adulthood, the tip of the spinal cord ends at the L1. So any puncture site must be below the termination of the spinal cord, preferably at the L3, L4 interspace, both in adult and also in pediatric patient. And also it is verified through the PITS protocol and also other textbooks. And then this is because where do we locate the puncture site? Is we use several landmarks. So first, we need to locate the highest point of the both iliac crest and draw an imaginary line that connects these 2 points. And then the intersection between this line and midline spine is approximately at the level between the vertebra L3 and L4, as you can see in the left picture. So the red line, the red dotted line is at the L3, L4 vertebra interspace. So we must puncture the needle at that space. So when is the time that we use the lumbar puncture? There are several indications for lumbar puncture, but the top two is the crucial and commonly done. If there is the first one, if there is any suspected CNS infection like meningitis and also encephalitis, we perform lumbar puncture to analyze the CSF. And then if there is also any suspected subarachnoid hemorrhage, we can also do lumbar puncture to see whether there is presence of blood or red cell in the CSF. So and then there are also other indications like diagnosis and treatment for idiopathic intracranial hypertension, used for diagnosis of neurologic condition like Guillain-Barré syndrome, multiple sclerosis, diagnosis of pediatric metabolic disease like inborn error of metabolism. Also can be used to intrathecal chemotherapy and also for spinal anesthesia. However, not all patient is approved for lumbar puncture to be performed. So there are several contraindications for this lumbar puncture. First one, if there is any suspicion of increased intracranial pressure, it cannot be done. Why? Because it can cause cerebral herniation, which can lead to death. So in order for us to prevent this matter, to check whether there is increased ICP or not, we can do we can look through the signs and symptoms. If there is any no, sign and symptoms for increased ICP, we need to check the blood pressure and also fundoscopic sign for this patient. And then in order for us to confirm, we need to do the CT scan and also MRI brain before the lumbar puncture to be performed. And then second one, since the patient might have some kind of bleeding during the puncture at the puncture site, it is also cannot be done for patient with high risk of bleeding tendency. So because it can cause complication, bleeding more often, high bleeding. So we need to check the coagulation profile, the platelet count, if there is any prolong of PT and also APTT. And the third one is also cannot be done for patient who have skin infection like cellulitis over the site of lumbar puncture. This is because it can increase of carrying the infection into this area. So when we put the needle, the infection also can get through this patient. This can complicate it with the presence of sepsis if we still do the puncture site at the skin infection. So we can prevent it by check if there is presence of skin infection at the other side, like L4, L5. So we need to check if there is any infection. And then also for patient with respiratory stress and also hemodynamic instability, also it is avoidable for this patient to perform the lumbar puncture. And then we go to the crucial part, which is the preparation. There is also several processes that need to be done. Mainly covers the evaluation, counseling, and also equipment process. For evaluation, we need to make sure that this patient is fit enough for this process, and for that, we need to monitor their oxygen saturation, if their vital signs, or if there is any sign of infection, and also imaging before the lumbar puncture, like the CT scan and also MRI brain. And after that, we need to give it's also important for us to give a clear explanation regarding the indication, the urgent indications, why do we need to do this lumbar puncture to this patient, also the details of the procedure. And then it's also nice if we can get a written informed consent, because we know that although this lumbar puncture is quick and simple procedure, it also can have complications. And then we have to get through the equipment. So the main component or equipment that we need to get is the spinal needle, the stylet needle, for 20 to 22G length, by default 1.5 inch with also the stylet. However, for children who is above 20 years old, is mainly use the 3.5 inches. This is the main component, and this the list can refer later. And then we need to get to the procedure. The first one, we give sedation so that the patient will be stabilized, unconscious. So if there is important, because sometimes the pediatric patient or child, the child will move around and also crying, so it will be difficult for this process to get done. And also we need to apply the local anesthetic, mostly 30 or 45 minutes prior to procedure, so that the patient will feel numbness at the site. And then we need to the positioning, either lateral recumbent or lateral decubitus position, or mainly and also can be done by sitting position. This positioning is same in pediatric patient and also in adult. Then we identify the puncture site, arterial pointers with, like what I have mentioned earlier. And then we clean the puncture site to povidone iodine and also 70% alcohol. This is what I found in PITS protocol also. And then we need to we clean the puncture site and also drape the puncture site area. And then for the insertion of the needle, we gently insert the spine needle perpendicular to the puncture site and points towards an umbilicus. And then how far do we need to get to the needle? According to my research, we need to advance the needle until a gift is fed in order for us to detect the change in resistance. If there is any change in resistance, most of the time it shows that the needle has been penetrate the dura metal site. So if we go advanced little more, we can get through the subarachnoid space and to get the CSF. And then if we are confirmed to have we are locating at the suitable site at the subarachnoid space, we withdraw the stylet and check for the backflow of the CSF fluid. And then also we can also measure the opening pressure by detaching the manometer along with the stylet needle. And then if there is backflow of the CSF, we collect the CSF in the designated bottles, mainly 4 designated bottles. And then after we collect all of the CSF fluid into the designated bottle, we gently withdraw the needle, spray off-site, and also cover with gauze and bandage. And after that, we ensure, mainly with also the gauze and bandage, we ensure that the child will lie supine for the next 4 to 6 hours and continue monitoring the child until he or she becomes fully conscious. And then I guess this video I would like to show mainly regarding the procedure only.
Cleaning of the site should be performed in a circular motion, working from the inside out. Clean well beyond the area you will drape with chlorhexidine and betadine. Do this 3 times. The baby's diaper should be off by this point. Place your drape so as to create an opening through which everything is sterile. There are a number of different ways to drape the child. One is shown here. It is now time to perform the procedure and obtain the cerebrospinal fluid. Remember that your needle must have a stylet in it. The stylet needs to be in, or else tissue can be pushed into the spinal canal. This can cause a devastating local reaction. Make sure that you are comfortable. Many people prefer to be sitting during the procedure, in which case it is important to make sure the surface that the infant is on is at an appropriate height. Stabilize your dominant hand on the baby's sacrum and aim towards the umbilicus. You should aim towards the umbilicus so that you can pass between the spinous processes. If you go in perpendicular to the skin, you are much more likely to hit bone, as you can see in this model. As you move the needle in, you may or may not feel a change in resistance, often called a pop. If you're not sure if there has been a change in resistance, periodically take the stylet out and see if there is CSF flow. If you cannot get flow, put the stylet back in and go a bit further. Recheck periodically. Once you have flow, collect the fluid in 3 to 4 tubes. If you can, get about 1 centimeter in each tube. Reinsert the stylet, take the needle out and put pressure on the site with gauze. You can then dispose of sharps. Put a band-aid on and tell the patient and their family that the child should remain supine for at least 30 minutes to minimize the potential post-tap headache.
So that's all for the procedure, and then we go to the last part, which is the complication. So there are several complications that commonly present. That can be present along with the lumbar puncture process. So the red one is common, while the blue one is rare, since it can be avoided through adequate examination, and also referring to the contraindication like the hematoma, bleeding tendency, cerebral herniation, increased ICP, infection, like the infection at the puncture site. To prevent the post lumbar puncture headache, which caused by leakage, continuous leakage of cerebrospinal fluid. You can have several prevention, like using a thinner needle, use a traumatic needle, and also we can insert needle with bevel parallel to dural fibers. Also, along with the supine position, somehow it can prevent a severe headache. And then for post lumbar puncture back pain, commonly it resolves without intervention and resolve for several. It will be resolved after several days. For hematoma, avoid patient with high risk of bleeding, cerebral herniation. We check the ICP, neuroimaging. Also avoid in high risk patients like patient in hypertensive and encephalopathy, since it is the most serious complication that can lead to death. And infection with this aseptic technique. So I guess that's all from me. It's my reference. Thank you.
Okay, next.
Are you present? I will start. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Wait,
Yes.
hi.
Yeah. So my name is Nur Ada Akila binti Manase. I will continue with head, weight, and head circumference. So next. So before we go to our main concern today, which is the measurement. So let's take a look on the. Huh?
Nuaida. Nama siapa?
Nur Ada Akila.
Ya. Nuaida Akila. Okay.
Okay. Okay. First let's take a look on overview of anthropometry. So anthropometry is the study of measurement of human body. So this word actually is derived from the Greek word, which anthropo means human, while metro means measure. So anthropometry is a key component of nutrition status assessment in children or even in adults. So example of anthropometric measurement are listed in the box, as you can see on the left side of the slide. So in pediatric, the essential growth measurement in infants and toddlers to age 2 years old are length, weight, head circumference, and also weight for length. For children aged more than 2 years old and above, the essential growth measurement are head, weight, and also BMI, body mass index. So next. So we move to the head measurement. So depend on a child age and ability to stand, we measure its height, whether in length or height. So a child length is measured by lying down, and this measurement were indicated to the child less than 2 years old using infantometer, while height is measured by standing upright and indicated for child age 2 years old and above, and they are able to stand using stadiometer. Next. Okay. Now let's take a look on the technique in measuring the child length. So first, we need the equipment, infantometer, and 2% in order to have an accurate measurement. So the first person should be their mother. So it will come the baby, while the other is the clinician or pediatric or healthcare provider. So first step, we explain everything to the mother on what she needs to do. So ask her to place their baby in the supine position on the length board on the baby's back and the baby's head against the feet's headboard. So we, the clinician, hold down the child's leg with one hand and move the footboard with other hand. So make sure to apply gentle pressure on the baby knee to avoid any injury. So while holding the knees, we pull the footboard against the child feet and we record the length to the nearest 0.1 centimeter. So next, we look on the technique in measuring the height for a child. So first, we help the child to stand on the base of stadiometer as in the picture with their feet slightly apart and make sure that their shoes, sock, and also hair ornaments have been removed. So once the child stand in the right position, with their back in contact with vertical space of stadiometer, we pull down the headboard to rest firmly on the top of the head and compress the hair. So we record the head to the nearest 0.1 centimeter. So next, we look to the weight measurement. So for weight measurement, I divided into three parts, which are for child under 2 years old, child age more than 2 years old, and child under 2 years old where they are unable to stand firmly on the scale. So next. So first, for the child under 2 years old, we use electronic baby scale or pediatric beam scale to measure the weight. First, we ask the mother to undress the child and left the child naked. Then we put the baby on this calibrated scale and we measure the measurement to the nearest 0.1 kilogram. So next is for the child age more than 2 years old and able to stand alone. So we use weight standing scale for this type of measurement. So first we ask the child and their guardian to help the child to remove the shoes and the outer clothes if possible in order to get accurate measurement. So then we ask the child to stand still with feet slightly apart on the scale and record the weight to the nearest 0.1 kilogram. So next, so if the child is unable to stand still alone or they have problem to use the previous weight measurement, we do a third weighing. So for this, we will use the Uniscale. This is the recommended scale that was made by the UNICEF. So this scale need adequate lighting to function. So for the technique, first we ask the mother to remove shoes and stand on the scale where other people hold their baby. Next, after mother weight appear on the display, tell her to remain standing on the scale so that the health provider can tear the scale by reset the reading to 0 by covering the solar panel if they use Uniscale, since Uniscale need a light to function. So then we gently hand the naked baby to the mother and ask her to stand still. So the baby weight will appear on the display and we record the weight to the nearest 0.1 kilogram. So next, we move to the head circumference, or we also call them as occipitofrontal circumference. So next, next. So head circumference is generally measured on infants and children until the age of 3. We use a flexible, non-stretchable measuring tape. So head circumference is measured over the most prominent part on the back of the head, occiput, and just above the eyebrow, supraorbital ridges, as on the photo provided. So we measure the recording to the nearest 0.01 centimeter. So next, we finish with the measurement. Now we'll look at the growth chart. So growth chart is a series of percentile curves that illustrate the distribution of selected body measurement in the children. So the importance of growth chart is to allow the healthcare provider or the pediatrician to follow the growth of a child over time. So two growth charts are currently recommended for use by the pediatrician. So CDC recommend use WHO growth chart for infants and children aged 0 to 2 years old. Meanwhile, for CDC growth chart for child aged 2 years and above. Next. Now let's learn on how to read and use the growth chart. So as we know that there are a lot of growth chart that we can choose. So for the first step, we need to choose the correct body measurement that we want. Just like in the photo given on the left side of the slide, I choose length for age for a female child, and growth chart is from birth to 2 years old. Note to you that the growth chart for female and male are different, so we need to be more careful in choosing the growth chart. So now, time for us to plot the chart. To plot the chart, we need to find the age on the x-axis, as you can see, and the body measurement on the y-axis. Then we plot the chart as in the photo. As you can see, the intersect one, the cross one, follow the line to the right side of the chart. So the zero label on the chart, as you can see on the right side of the chart, it means average or median. While plus 3 or plus 2 or negative 3 is Z score. So the zero or average line is the average or normal growth pattern. So it is normal for a child to be a little above or below the average line during visits to the doctor. So if the growth over time start to cross more lines or percentiles or falling off the curve, it may indicate health problem in the child. So, so from the chart given, we can see that the plotted line is parallel to the mean or average line, the zero line. So this means that this child line is normal because it's nearest to the median line, the average line. So next, this is the normal value for anthropometric measurement in pediatric. I think that's all from me. Thank you. Is there any question?
Okay, this one, you all
Yes.
have to know in detail, because the exam will be part of the exam will be something like this, how to chart and how to interpret, very important. And I found out many of you really lacking is the head circumference. So proper head circumference you must know is just above the occipitofrontal. The frontal just above the eyebrow. Remember that. And occipital. There's something that you always forget. Very important. Okay. It will come out
Okay,
in your exam. One of those techniques. Okay, come next.
okay, thank you, Doctor.
Hmm.
Assalamualaikum warahmatullahi wabarakatuh. Can all of you hear me?
Yes.
Yes.
Okay. So my name is Nur Izati Amira binti Izani, and I will present on the endotracheal intubation in pediatric. So this is my outline for my presentation. We start with indication, followed by contraindication, procedures, and also complication. Okay, as for introduction, endotracheal tube, it's mean by placement of a tube into the trachea, either orally or nasally for airway management. And this indicated for when patient have when the insufficient back and mask ventilation or continuous positive airway pressure. And it also indicated for prolonged positive pressure ventilation, direct suctioning of the trachea, maintaining and protecting the airway, and also diaphragmatic hernia in newborn. So what is the contraindication? So the contraindication is the inexperienced operator. So to perform this procedure, there's needed assistance from the senior doctor in pediatric or anesthesiology department whenever necessary. So if inexperienced operator in found not found when the inexperienced operator need to resuscitate the patient in emergency, they need to perform back and mask ventilation. But this is contraindicated in diaphragmatic hernia. Okay, so this is the equipment.
Go back. Sebelum tu. Slide sebelum tu. Selepas forward. Okay. Okay. Continue.
Okay, so this is list of equipment needed in endotracheal intubation. The first one is bag and mask with high flow oxygen flow. Second one is laryngoscope. Third one is blade or blade, and fourth one is stylet. Then this is to guide, and it is optional. Next one is adhesive tape, and this used to secure the position of the tube, pulse oximetry, ECG monitoring, and also a suction catheter. Sedation such as midazolam or morphine also needed to sedate the patient, and sometimes muscle relaxant such as succinylcholine and rocuronium sometimes needed to ease the intubation. Okay, moving on to the procedure. So this is the list of procedure that mentioned in pediatric protocol 4th edition, but I will explain in easiest way using this diagram. Okay, for the step 1, the clinician or pediatrician
No
need
need
to
in
tilt the
detail lah.
patient.
No need in detail. You're not going to learn it. You're not going to understand at all. Just basic only.
Okay, doctor. So the step 1 is you need to place the patient.
If you give a detail, 1 jam pun tak habis.
Okay, doctor. Okay, thank you, doctor.
Tak
So
payahlah
I will
detail-detail
continue.
macam tu. Proceed lah.
Yeah, proceed. Thank you, doctor.
How many steps is that?
5 only.
5.
Yeah.
Okay lah.
For the step 1, we need to tilt patient head and open patient mouth by pushing lower jaw with thumb and pushing upper jaw with index finger. And we insert laryngoscope from left side of patient mouth, moving aside tongue and locating the epiglottis. So this is the position or the way. The step 2 is when after you insert the laryngoscope, do not pull backward on laryngoscope, or you will risk injury to the patient teeth. But you need to push forward and upward to lift epiglottis to view trachea and also vocal cord. For step
Hello,
3,
Assalamualaikum. Taufik, meeting strategi tu meeting apa?
Okay, for step 3, we insert lubricated endotracheal tube via side of mouth, so it's not obstruct the view.
Dia nak hantar berapa ramai, nak hantar MO semua for ni.
Intubation is not done within 20 seconds. The attempt should be aborted and reventilate the patient with bag and mask.
Berapa yang kita hantar, berapa training, berapa ramai nak hantar semua.
While holding endotracheal tube in place, remove laryngoscope and pull out the stylet from inside endotracheal tube.
Tanya
And the last step is
tanya nama
attach
yang beri tu.
end-tidal carbon dioxide detector and move back to endotracheal tube. And squeeze the bag at
Masrur tak
regular
nak.
intervals to
Masrur dia
begin
tak nak.
ventilation.
Dia nak
And
break.
if the detectors turn go, a tube is
Apa
ventilated and checked for biological lung
I submit Fitri dengan Masrura.
secure endotracheal tube with
Tapi yang
tape
penting
and
dapat
attach
2 pos.
ventilator to the embo bag.
Tak apa dah, dapat 2 pos je dulu. Doesn't matter siapa.
This is the video,
Ah,
but I think
doesn't matter because dia next week dia interview. Minta 2 daripada Sophie. So yang ini ada Fitri mungkin tak dapat. Iza mungkin Safi tak. I hantar nama ke Izian, Fitri dengan Mazura. Yang mana? Borang yang mana? Borang untuk tak apalah. Tak apa, ambil 2 pos dulu. Doesn't matter. Nah, Mazura tak nak. Sebab she want to take exam. Tak nak, Mazura tak nak. Dia nak ambil exam. Tak apalah. Tapi minta 2 pos. Tak apa. Just 2 pos. Jangan dengan suspect. Dia hantar 3 orang nama. Safi, Fitri, Neza. Tapi I tak sure Fitri going to get. Safi dengan Iza. Tapi so what you do that, you still minta 2 pos daripada kau. 2 pos kata 1 Fitri, letak yang Mazura dulu, tak apa, it's okay. Letak yang Mazura. Tak apa, it's okay. Kita tahun depan lah, because it will be, yang penting nak booking dulu tempat tu. Because tempat is limited. Once somebody else, bila somebody else ambil, terus tak dapat, kosong. Siapa? Patut dia ambil ya? I don't know about that. I tak tahu. I don't know about that. Okay, tak apa, nanti tanya Izian ke apa. I don't know, you don't tell me. Nanti I tanya. Kalau I know, I would ask the Prasmi kenapa dia buat tu. Okay, nanti I tanya dia apa. You tanya lah, yang you tanya ni. You tanya. Tapi ada kata nama ada bui, kenapa dia orang tak sama, dia tak continue, dia tak ni. Nanti I tanya. Okay.
Ensure you have all equipments ready for intubation. You need another person to help you for providing supplies, for assessing the heart rate, and for informing the oxygen saturation.
Continue.
Diagnostic asepsis during the stand and
Okay, I will continue. So for the last part is complication. So the possible complication is esophageal intubation. Usually this is when the endotracheal tube could be in situ initially, but can dislodge and can enter the esophagus. Okay, the second complication is right line intubation, trauma to the upper airway, and it this procedure also can cause pneumothorax. And the last one is subglottic stenosis. And subglottic stenosis is narrowing of the airway, and this can be fatal to the patient and need medical intervention. But this subglottic stenosis is rare complication. So that's all from. So this is my reference, and that's all from me. Thank you.
Can you hear me?
Tak dengar sangat lah.
Bismillahirrahmanirrahim. Okay, my name is Sharifah Hajar binti Said Jamaluddin, 1813106. I'll proceed the presentation with the title of nasogastric and orogastric tube insertion. Okay, so this is the outline, definition, indication and contraindication, preparation and procedure, confirming the placement and documentation, and lastly, complication. Okay, so for the definition, nasogastric tube is a small tube that is inserted into the stomach via the nasal passage.
Tadi attitude siapa tadi?
What?
Attitude. Sorry, siapa nama dia?
Nur Izzati Amira, doktor.
Okay, can I proceed?
Okay.
Okay. So for oral gastric tube, it may be used particularly if the nasal passage are compromised or being used to administer the oxygen. Example like continuous positive airway pressure. Okay, so what are the indication and contraindication for this tube? For indication, it can be used to drug administration, feeding, expiration of ingested substance, rehydration, and decompression of stomach. Usually, the feeding is indicated because of the prematurity or critical illness or any anatomic defects, like mouth cannot eat. Okay, for contraindication, post-operative period, like post-operative period, non-structural abnormality, upper gastrointestinal stricture or obstruction, suspected nasal, maxillary, oropharyngeal or esophageal trauma, and also bleeding disorders. Okay, so first and foremost, we need to prepare ourselves and also the equipment. We need to wash our hand and don PPE if appropriate. We need to introduce ourselves, confirm the patient's name and date of birth, explain the procedure to the caretakers, and then gain consent and check for patient allergies, and ask the patient if have any pain before continuing the clinical procedure. So what are the equipment that we need? We need a pH testing strip, syringe, lubricant, nasogastric tube and dressing, gloves and apron, disposable bowl and glass of water. Okay, so for gastric tube size, it based on the age, newborn 6 FG, it is a French gauge. This is just a measurement in French. 1 FG equal to 1/3 of millimeter. So 6 FG divided by 3 is 2 millimeter diameter. Okay, so for procedure, first we need to position the child in the supine position. The head on the bed may be flat or preferably elevated as the child's condition permits. Okay, after that, we need to measure the tube from the tip of the nose. You see my cursor? From the tip of the nose to the earlobe, and then from the earlobe to the midpoint between the xiphoid and the umbilicus. And then mark this point on the tube with marker or small piece of tape. Okay, after that, we need to lubricate the distal tip of the tube with a water-soluble lubricant, and then gently but steadily thread the tube through either the mouth for the orogastric and for the nose for the nasogastric to the previously identified mark. And then we can instruct the patient to swallow, observe for excessive gagging, coughing, wheezing, apnea, or color change. This may be because of the passage goes into the trachea. So we need to re-advance when the patient is stable. And if there is resistance, withdraw a bit and rotate slowly and downward. I will show the video after this. Okay, so for confirming the placement, note the external length of tube at nostril, and then gently aspirate a small quantity of gastric fluid with syringe and check for pH on pH indicator paper. So usually the pH is between 1 to 4, or it can be below than 5.5. And then ensure the external length of tube remains unchanged.
Assalamualaikum warahmatullahi wabarakatuh. Serahkan kepada semua Dr. Sultan Ahmad Syah Medical Center, para pesakit dan kawan sekalian.
So what
Solat Zuhur akan masuk dalam tempoh 10 minit daripada sekarang.
we are on
Kita dah sama-sama menunaikan solat di awal waktu. Kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, solat di awal waktunya.
to check
Solat fardu boleh dilaksanakan secara berjemaah demi SOP yang telah ditetapkan. Adalah dimaklumkan bahawa tiada pegawai dibenarkan untuk merawat pesakit dalam tempoh PPP. Hanya seorang pegawai dibenarkan untuk menjaga pesakit di ward pada satu masa. Terima kasih.
Doesn't get again, we need to start back in step 1 and then inserted again, reposition 1 cm in or out. Okay. If you cannot again, please seek for assistance and then check for the procedure. Okay. Okay. For after that, after we done with the procedure, we need to do documentation. First, you need to comfort the infant or child, and then dispose all the equipment and check for the heart rate, respiratory rate, oxygen saturations, and also write down the type, size, date, pH and color, and then the size of the tube, and notify any problems or abnormality. Okay, so for complication, complication can happen when it is when there are tube misplacement.
No, I will WhatsApp Azan tanya kenapa. You next time told me all this thing tau.
Of the gastric
Oh,
fits,
you tak boleh marah apa Hasmi, I boleh tau. Dia satu level dengan I.
aspiration associated
Senyap macam ni, how I know.
and trauma to surrounding tissues.
Yelah, last week pun inform me lah last week. Sebelum I jumpa dengan dia, bila I kadang jumpa dia minum dengan dia.
It can cause feeding intolerance.
Quiet like this, I don't know. You all memang, you tak ada influence apa-apa.
And
No, dia jentik you all, tapi I can marah ke dia.
Okay, I will show the.
Nantilah, I proceed. Nanti I tanya dia, I call dia tak jawab. Nanti I tanya dia balik direct, why dia tak beri. Dia itu doesn't matter. Kita plan for 4 years. Itu different matters. Dia doesn't matter. Dia 4 years lagi. I can talk to
Tube is in the proper place in the stomach. To do that, measure how much tube will be placed inside the child by placing the tip of the tube at the nose and lay it at the bottom of the ear,
Don't inform me anything.
then to the bottom of the breastbone, called the xiphoid, to the belly button. The tube should be laid out to the spot halfway between the belly button and the tip of the breastbone. Mark that spot with a marker or make a mental note of the number, which is the centimeter mark, and go to that number. Measure the tube each time you put it in. Some tubes have a longer tip because they have weights. When you measure, be sure to put the first hole where the formula will come out at the nose and not the tip of the tube. Position the child with the head up, and for infants, you will want to swaddle the baby and have someone hold the head and body while you insert the tube. A pacifier will help the infant swallow while the tube is going down. For a toddler, hold them in your lap, securing the head, body, and legs while someone else inserts the tube. For an older child, have them sit up and sip water through a straw to help with swallowing. A key point to remember here is to keep the head straight and not allow it to tilt back, which opens up the throat to the lungs. Lubricate the tip of the tube in water-soluble lubricant or water. Once the child is secure, place the tip of the tube in the nose, angle it toward the center of the nose. Gently push the tube down the nostril until you reach the mark on the tube that you made when you measured how long the tube should be in to be in the correct spot in the stomach. If you feel a blockage, pull back a little bit and try again to reinsert the tube. The child may cry or gag, but if they cough, choke, or have trouble breathing, pull the tube back. Retry once the child calms down a bit. This is also where you will want to blow in the face of a smaller child or baby to get that startle reflex and swallow. Remove the guide wire if used and check the pH, which I will explain in just a minute. Tape the tube as close to the nose as possible. The tube should not press on the nose, as it might cause a sore to develop called a pressure ulcer. Make sure you can see the mark that you made or the number so that you can tell the tube has not moved. Inserted should always be seen at the nose. Is not the same at the nose. You should remove the tube and follow the steps of inserting the tube again. Attach an end-fit syringe, usually a 5 or 10 mil, to the end of the NG tube. Pull back gently on the plunger and check pH using the fluid obtained. pH measurement represents the acidity of the stomach fluid. The lower the number, the more acid is present and is a good indication that the tube tip is in the stomach. When you pull out the stomach fluid from the tube, put some of the fluid on a small piece of pH paper and match it to the pH paper grid or to the pH strip canister. The stomach fluid should be at a pH level of 5, 5.5 or less. Your healthcare team will tell you the cutoff number they recommend you use.
Okay, that's all. I think that's all from me. This is my reference. Thank you.
Okay. Ada lagi?
Ada doktor, lagi satu.
Okey,
Okey, sekejap. Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Dato Nazifa binti Rosari, and I'll be talking about intravenous catheter placement and also venipuncture. Okay, so we'll start with intravenous catheter placement. So for the indication of IV placement, first is to replace and maintain fluid including electrolytes such as
Roda.
Rauda.
Okey,
Okay, for the indication of IV placement, first is to replace and maintain fluid including electrolytes, such as when the patient has fluid loss related to decreased intake or diarrhea, so the patient may require intravenous therapy. Second, to administer blood and blood products, such as when the children require surgery, so he or she will require extra blood from the donor, or when they have hematological problems such as hemophilia. And the third one is to administer medication such as chemotherapy or analgesic. And the fourth one is to deliver nutrition and supplements when the patient's unable to obtain adequate amounts orally or by other routes. However, usually most children do not need vascular access for drug or fluid therapy because the medication can be administered through orally, transmucosally, or inhalation. And also finding veins might be challenging due to small size of the vessels. And these are the types of intravenous. We have peripheral intravenous and also central intravenous. As a comparison, peripheral intravenous sites are most common one at the dorsum of hands and also feet. And the next one is antecubital fossa at the elbow, where there will be location of cephalic, basilic, and also cubital vein. And for scalp, for infant less than 1 year old. And for the central intravenous, the sites are at subclavian vein, internal jugular vein, and also femoral vein. And the most common site is at subclavian vein. And for the purpose of peripheral intravenous is when other routes are not available. The other routes, as I mentioned before, oral, inhalation, or transmucosally. And for short-term medications such as under 6 days, and also for solution that are isoosmotic solution. And for central intravenous, the purpose are for central venous pressure monitoring, long-term, such as more than 1 year, like dialysis, and also to administer hypertonic solution. Why is peripheral intravenous only for isoosmotic solution is because as we know that blood flow at the peripheral is lower. So when we administer hypotonic or hypertonic solution, so it will cause osmotic pressure gradient. So cells from the cells will draw out blood or the blood or water from the vessels will move into the cells, causing rupture or shrinkage. And for and hypertonic solution can be administered at the central because blood flow there is more laju than peripheral, so it will not cause any pressure gradient. And this is the peripheral intravenous equipment. We have gloves, tourniquet, alcohol pads, gauze pads, 22, 24 gauze venous catheter. This is the size for pediatrics. Saline flush. The saline flush is to flush in at the catheter as the first step in order to reduce any risk or complication. The next one is intravenous tubing, solution or pump. And the last one is protecting covering intravenous such as small plastic cup and also tape. And for central intravenous equipment, actually it depends on the types. We have 4 types of central intravenous. I will just mention, you can read it by yourself later. We have percutaneous CVC, peripheral inserted central catheter or known as PICC, tunnel CVC or known as Brovac, and also implanted CVC. So usually the equipment will come in pre-packaged like this. This is example of PICC equipment. And then I'll show the procedure for peripheral intravenous catheter placement. Okay. Sorry. Okay. Now we'll proceed to the central intravenous catheter placement procedure.
A Metaport or Broviac catheter is inserted during a simple surgery. During the surgery, your child will be given a general anesthetic so that they can sleep through the procedure. For a Broviac, one end of the catheter is placed through a small incision in the neck. This is called the insertion site. The catheter is threaded carefully through the large vein in the chest. The other end of the catheter is threaded through a tunnel beneath the skin and will come out of the chest through another incision called the exit site. A Broviac catheter has a cuff that is buried under the skin. The cuff keeps the catheter in place so that it won't move around or get pulled out of the body. The cuff surrounds the catheter to prevent infections. The catheter will be stitched at the end to help hold the line in place until the skin grows around the cuff. These stitches usually dissolve or are taken out by a doctor. For a Metaport, one end of the catheter is placed through a small incision in the neck or insertion site and threaded carefully through the large vein in the chest. A pocket is created for the port to sit in and closed with a few stitches. You might feel or see a slight bulge under your child's skin where the port is located. Sterile dressing will be placed over the port to prevent infection. After the procedure, the insertion and exit site is covered with special pieces of tape called steri-strips. Steri-strips will fall off once the sites are healed. The procedure to insert a peripherally inserted central catheter, or PIC, can be done in a procedure room or at your child's bedside depending on the child's age and development. The child will receive a numbing medication on the skin where the PIC will be placed, and additional numbing medication right before the catheter is inserted into the skin. The child will also receive sedatives or relaxing medications during the procedure. A child life specialist will be there to help comfort you and your child and help your child understand what is happening. The PIC will be threaded into a vein in the arm above the bend of the elbow and guided into a large vein in the chest. The catheter is fixed onto the skin with a securement device and covered with a sterile dressing. For an infant, a PIC may be inserted into the arm or leg. After the procedure, the child might feel mild soreness around the insertion site. While your child is in the hospital, special wipes called chlorhexidine gluconate, or CHG wipes, will be used once a day to wipe down your child's skin.
Okay, now we'll move to the contraindication. So for peripheral intravenous, the contraindication is when non-invasive method available, such as orally or inhalation. And generally for both, the contraindication is do not place the intravenous catheter at cellulitic skin, at the wound, at the injured veins such as burn, and also to the patient with bleeding diathesis or known as have easy bleeding tendency. And for the complication, so we can classify peripheral venous catheter complication into local and also systemic. So for local, we'll have phlebitis. Phlebitis is the inflammation of the veins inner lining, that is tunica intima. And we will overcome it by immediately remove the cannula and elevate the arm or apply a warm compress. For infection, there will be purulent drainage from the site, and usually it will be noticed 2 until 3 days after an intravenous site is started. And for infiltration, it will occur when intravenous solution, but the solution is a type of solution that will not irritate the tissue, and it is accidentally administered into surrounding tissue. While for extravasation, it is when medication is administered and it accidentally leaks into surrounding tissue and will cause damage to surrounding tissue. The difference between extravasation and infiltration is that the type of fluid. For infiltration, the fluid that is not irritate the tissue, while for extravasation is fluid that will irritate the tissue. And the last one is for hemorrhage. There will be hemorrhage at the puncture site. And for systemic complication for peripheral intravenous placement, there will be air embolism. That is the presence of air in the vascular system and occur when air is introduced into the venous system and it will traverse to the right ventricle or pulmonary circulation. The next one is catheter embolism, occur when a small part of the cannula breaks off and flow into the vascular system. And lastly, the catheter-related infection, where microorganisms are introduced into the blood through the puncture site and lead to the bacteremia or sepsis. And for central venous catheter, we have mechanical complication. That is when during insertion of the CVC, due to failure to correctly place the catheter, which may lead to cardiac arrest, pneumothorax or hemothorax. So it's important to verify the location of the tip catheter using X-ray after done the procedure for central intravenous placement. So the next one we move to venipuncture. So venipuncture is actually for blood sampling, that is blood taken from the vein. The common site is at the antecubital fossa for pediatric or for children more than 2 years of the age, and at the dorsal of the hand for children less than 2 years of the age. And for equipment, it is similar to the intravenous placement, just that it have blood collection tubes, syringe of 1 until 5 ml, wing steel needle, and also extension tube, that is the butterfly. So this is the procedure. Okay, so the next one we move to the contraindication and the complication. So the contraindication is SMS intravenous placement. Do not do this in the children with bleeding diathesis. And for the complication are hematoma and also prolonged bleeding. Hematoma is when blood leaks to the surrounding tissue, and prolonged bleeding for infants that take blood thinner or patients with coagulopathies. So I guess that's all. This is my references.
Okay, any question? No question, okay. Okay. Another one is the IV line is called infection.
Yeah.
Vasculitis. Okay, finish.
Thank you,
The next
Doctor.
one will be next week, kan?
Ya, next week ada lagi 4 orang.
Okay.